All right, good morning. Before we get started, I need to make an announcement, which is sort of not an announcement, but we've, part of the PCEP, part of the reason we have PCEP is that you can qualify for your National Registry requirements for those of you who keep up National Registry, which I still recommend that you do. For a lot of reasons, but the National Registry has changed their rules a little bit, and we refer you to the National Registry site, and then we will publish sometime in the next month or so the rules also for you. But when you aren't able to attend the live PCEP presentations and you watch it instead on the tape or online, that's called distributive education. And they've changed the rules as to what you have to do for how much distributive education you can count for credit. The bottom line is that you can't do all of it by watching it on tape. You can do, and they've changed it a bit. It's roughly, you're going to be, to keep up National Registry, you're going to be required to do at least half, essentially, of your PCEP live.
Correct.
So that's a change in the rule. Before it was a different hourly rate. You could count about almost 2/3.
Before it used to be whatever the medical program director's office said was a 48-hour cert, and we'd give you the cert, and we'd call it National Registry recertification. Now they have criteria on how much you can watch on tape, and now your 2 yearly requirement instead of 72 hours is 60 hours, and 35 of that can be taped. The rest of it has to be in person.
Right.
Somehow.
So it's not a big deal, just a sort of a, and it counts it live if you're on duty at the station and you can watch it on CVTV. That's counted as live. That's okay. So, okay, on to 12 leads, EKG, and STEMI. We've been having a lot of interesting STEMIs recently, and just as an interest for you, up until last June, the false STEMI activation at Peace Health Southwest was 32%. Since June, as of January, the false STEMI activation was 3%. Now, you would think that's because we're gotten so good at doing STEMIs, but that's not true. That since Pulsera has come off, we've sent the 12 lead to the ED, and the ED doc gets to looks at it and says, yeah, I agree, that's a STEMI, or it's not a STEMI. And if the ED doc can't decide, because that sometimes happens, he can send that on to the cardiologist on call, and he looks at it and says, he or she looks at it and says, yeah, that's a STEMI or not a STEMI. So our actual false activations have decreased, but it's because of the addition of Pulsera. Now, I still would like to say that or get to the point where our STEMIs, our false activation is 15% or so from the field, or our false call is 15%, because I want you to overestimate. I want you to err in favor of the patient, but we need to be able to do good 12-lead evaluation So, basic EKG review. Your P wave is the depolarization of the right and left atrium. The QRS is the right and left ventricular depolarization. Your STT wave is ventricular repolarization. A U wave, which is this little sucker that occurs right out here, is probably an after depolarization and doesn't mean anything except in a couple of odd cases, and so it's worth noting it, but not to get excited about it. QT interval is the duration of ventricular depolarization. When the QT is too long, it predisposes people to ventricular dysrhythmias, particularly torsades and things like that. The R to R interval is the duration of the ventricular contraction cycle. So that distance from there to there. P to P interval is the duration of the atrial cycle, and hopefully the two are the same. If not, you've got an atrial ventricular dissociation. Now, your standard limb leads. Right arm is always negative. The only reason of knowing whether things are negative or positive is that you have to think of the vector force going toward or away from that electrode. So right arm is always negative. Left arm is positive if it's referring to the right arm, but it's negative if referring to the left leg. The left leg is always positive. So when you look at lead 1, you're going to see if you have a positive upstroke of the P wave and the R wave. That means that the vector is moving from the right arm to the left arm. When you look at lead 2, it's going from the left arm to the left leg, so it's moving toward that left leg. And in lead 3, it's going from the right arm to the left leg positive. So it's moving down this way, it's moving across this way, and it's moving down this way, which means you have positive upward strokes in all those in your 1, 2, and 3. Precordial leads, much simpler. V1, right fourth intercostal space, V2, left fourth intercostal space, V3 halfway between V2 and V4, because V4 is in the left fifth intercostal space. V5 horizontal to V4, anterior axillary line, V6 horizontal to V5, mid-axillary lines, just working around the chest, starting from right to left. Now, if you do a V3, a V4R, it's just in the positions of V3 and V4, but on the right side of the chest instead of the left. Now, how do you read a 12 lead? You don't look at the ST segment first. I want the rate and rhythm. Is it fast, slow, normal for presentation? Yeah, you're treating the patient. If you say, oh, the patient's got atrial fibrillation, but the heart rate is 68, so that's normal. If it's 200, that's not normal. Is it regular? Is it irregular? Always remember, the most common irregular rhythm is atrial fibrillation. It's the big masquerader. It's the most common irregular rhythm. It's irregularly irregular. Is it supraventricular versus ventricular? Is it a wide complex? Wide complex, I want you to think of that as ventricular until you prove otherwise. A wide complex. Now, when you have atrial fibrillation, because it's the grand masquerader, so many times with atrial fibrillation, it's aberrantly conducted, so you get a wide complex. But it's really not ventricular. The rhythm and rate is not ventricular in origin. Axis. Okay. I sort of kicked myself and decided, should I even talk about axis? Because it's it's like the axis of evil. Do you really want to talk about it? Left axis deviation, why should you know anything about axis at all? Well, left axis deviation might suggest an inferior MI, if you can't figure it out already, or a paced rhythm, or an anterior fascicular block, the anterior fascicle of the left Purkinje fibers. Is it a right axis deviation? That suggests left posterior fascicular block or a lateral MI, if you can't figure it out otherwise, and right ventricular hypertrophy or acute right-sided strain. And then they have extreme right deviation, which is possibly VTAC, electrolyte derangement, misplaced limb leads. So, if you want to know axis at all, do it the simple way. Your normal axis, just look at lead 1 and lead AVF. If it's upright in lead 1 and upright in AVF, this is normal axis. And it's just, the way the way it is. Left axis, so you're thinking, oh, is it a fascicular block? Is it an inferior MI? You're going to be upright in lead 1, possibly downward, or downward in AVF. That's left axis deviation. Right axis is down in lead 1 and up in AVF. You only have to look at 2 leads. An indeterminate or extreme right axis is down in both V1 and AVF. And if you get that, always check your limb leads first and see if you've maybe switched them around accidentally. Then, if not, it's extreme right axis deviation or indeterminate. I'm not sure what it means. Now, you say, what if I can't tell with AVF? Lead 1, you can almost always, it's pretty straightforward. But AVF sometimes is kind of indeterminate. It's, maybe not, it's isoelectric. It's up and down sort of equally. You can't tell. Then look at lead 2. If it's up in lead 2, then AVF should have been up. And if it's down in lead 2, AVF should have been down. Makes it easy. So, looking at your axis, then you look at an injury pattern. If you, in this case, the vectors have all, so you're up in AVF, you're up in 1, and you're also up in all these other major leads. So you've gone from normal, you've swung slightly to this side. And that just means that's where your force of your vector is. Now look at your QRS duration. Is it normal? Is it prolonged? Note the QT interval. And you say, how can I measure QT? You can't. Well, you can, but you don't have the calipers and stuff to do. But the machine does it for you now. It should print out your QT, QTC. And you just have to know that in men, it should be less than 450. And in women, it should be less than 460. If it's more than that, then it's a prolonged QT interval. So think 464, if the machine tells you, so 464 would be slightly long for, that would be long for a guy. And that might predispose then to prolonged QT syndromes, which is the torsades type things. Now look at your morphology. If your QRS is wide, it has to be more than 0.12, more than 120 milliseconds, 0.12. Look at V1. If there's a terminal R wave, it's right bundle branch block. Terminal R wave means the last wave, last deflection in the QRS. R is a positive upward deflection. Left bundle branch block, there'll be a small R wave, but a deep S wave in V1. So you really only need to look at V1 to determine if you've got, almost all the time you can determine whether you've got a right bundle branch or a left bundle branch block with a, and it has to be a wide QRS. So, right bundle branch morphology in V1. So we'll look for, you've got a terminal upward, so you've got an R, R prime, you've got an R, R prime, you've got an R, R prime, all, the terminal wave is upward. Here, small r, and with an S, R prime. Here's a Q, R, R prime, a Q, R, that's a right, these are all right bundle branch blocks. This one probably occurred after, had an MI associated with it, and is now done with the MI. Left bundle branch block might have a little R wave, but a big S wave. V1, little R wave, huge S wave. R wave, big S wave. Or no R wave, big S wave. That's all bundle branch blocks. Now, if you look at V6, a lot of times you will get an R prime, which confirms it to you. But really, all you have to be looking at is V1. And lead 1 may have an R prime as well. Now, obviously, you need to know left bundle branch block versus right bundle branch block, because we're going to talk about STEMI mimickers. Now, but I will discuss that in a bit. So, STEMI, 1 millimeter elevation in 2 or more contiguous leads. 1 millimeter, and I mean 1 millimeter minimum. A lot of places do not accept in V1, 2, and 3, they won't accept it unless it's 2 millimeters. A lot of medical, now I want you to get it to have at least a millimeter, but you know, it doesn't have to be 2. If you got a millimeter elevation and it's real and not just a fake news. And then, does the patient have symptoms of acute coronary syndrome? Are they having chest pain? Are they having fatigue? Are they having diaphoresis? Are they having nausea? Are they having, if they're having stabbing chest pain when they take a deep breath, that's really not ACS symptom. Might be, but you need a 12 lead. Anytime you got chest pain, get a 12 lead. But do they have symptoms that makes you think that this guy's having a heart attack? If you go there, if you go and you see a little old person who's confused at a nursing home, and you smell the strong flavor of urinary tract infection likely, and they appear to be septic, and you do what I would like you to do, and you throw a EKG on them, and you say, oh my God, I think I've got a millimeter of ST elevation in lead 2, 3, and 4. Don't call a STEMI on that one, because it's probably not true. You're not there for a STEMI, you're there for sepsis. If you've got 5 millimeters of ST segment elevation, well, they darn well maybe they might have had an MI, and now they're, in shock and septic because of that. But you've got to make the symptoms fit with the patient. When they're 20 years old and they're having chest pain and they have a little ST segment elevation, it's probably benign repolarization rather than an MI. Do they have reciprocal changes? Reciprocal changes tell you a lot. If they have reciprocal changes, then what you see is elevation. Now you're seeing reciprocal depression in the opposite leads. That's probably truly a STEMI. If you see elevation in leads and the reciprocal leads, the opposite side leads, also have elevation, you think, that's kind of unusual. Maybe people don't have generalized STEMIs. That's probably then going to be pericarditis. So we just think. So think how these go together. So we're going to talk about STEMI, but what does the evolution of an MI mean? An MI is by definition, a myocardial infarction is, a STEMI myocardial infarction is a Q wave producing myocardial infarction, which means some tissue dies. And our goal is to minimize the production of Q waves by diagnosing a ST segment elevation myocardial infarction early and fixing it. And it gets fixed by going to the cath lab and having that artery opened by a balloon and having a stent put in after the fact to minimize the production of Q wave. But here's your production. So here is a normal, and as you start into the myocardial infarction, the ischemic process, ischemia occurs and you begin to have an elevation of your ST segment and hyperacute T waves. So the T wave probably gets wider, but certainly often gets taller. Doesn't peak it's still rounded at the top, so it doesn't peak like it does in hyperkalemia as much. Then the next thing is you get real ST segment elevation, significant elevation, and that's, of course, the STEMI. That's what we want to call at this level. Then and so the time period from here to here is minutes to hours. Then as this evolves, if you don't treat it, if you don't fix it, is the patient will start to develop a Q wave. And now that's usually 24 to 48 hours after the actual infarct. So you've got dead tissue. The Q wave means it's dead, that some of that tissue is dead. And you still have ST segment elevation, and you may have some T wave inversion, maybe biphasic. Then as it progresses to day 2, day 3, day 4, the Q wave gets bigger, and the ST segment comes down pretty close to baseline. Usually it's inverted T wave, and then over a period of 2 to 3 to 4 weeks, usually around 2, you get the Q wave firmly established. Q wave has to be wider. It has to be quite wide and quite deep. Usually it's about a 1/6 to a 1/4 of the size of the R wave. It's a prominent Q wave. You know it's there. That means that they've had the MI. So when you see when your machine says inferior myocardial infarction, uncertain age, that means it's seeing a Q wave in those leads usually. If it says acute myocardial infarction is suspected, it's probably really reading ST segment elevation. But you notice that the baseline now, the ST segment is at baseline. The T wave is normal. There's the Q wave. The R wave is back where it belongs. That's what's supposed to look like after you have a Q wave. A Q wave simply means you've had a full thickness myocardial infarction. An N-STEMI, a non-STEMI, means it's partial thickness, and it's a non-Q wave myocardial infarction. It doesn't give a Q wave. It means that some muscle has been damaged, but not full thickness. We mostly diagnose non-Q wave myocardial infarctions by enzyme changes because the EKG doesn't look like it's a STEMI, but the patient has symptoms, and so over a period of 6 to 12 to 24 hours, we get enzymes. If the enzyme level rises, that means they've had a non-full thickness damage to their myocardium. Now, how do you read a 12 lead? Your inferior leads are leads 2, 3, and AVF. Those are the ones facing the EKG. So the MI is facing those leads. So that's where you see the ST segment elevation. The reciprocal to inferior is 1 and AVL. High lateral, a lateral MI occurs in 1 and AVL. That's high lateral. So the reciprocal of that is leads 2, 3, and AVF. The anterior leads for an anterior MI are V1, V2, V3, V4. There's no true reciprocals, but a lot of times you will see reciprocals. There's no true reciprocal, but depending on how the position of the heart is in the chest, you may see reciprocals in inferior leads. Posterior, there's nothing facing it, but reciprocals are in V1, V2, V3. When we get to a true posterior MI, you will see the changes in V1 and V2, V3, but it's reverse of what you'd expect. So more news at 11, or about 10:30. Now, so EKG recognition of an MI, a Q wave pattern is your STEMI. That's going to make a Q wave if we don't fix this. It's a result of a total occlusion or near total occlusion of the artery with a homogeneous injury pattern to one segment of muscle. Non-Q wave is subtotal occlusion, and most of the time, if they're going to demonstrate anything at all, it'll be ST depression or T wave inversion. So when you're having somebody with chest pain and you look at it and in lead, let's say 2, 3 and AVF, you see ST depression instead of elevation, and there's nothing anywhere else, and the machine says suspect ischemia in inferior leads, it may well be a non-Q wave MI, an N-STEMI. So treat that acutely, but don't call it a STEMI as you come. You can certainly send that in by the Pulsera to the doc and let the ED doc look at it and say, hey, do you want to call this or not? And they won't. If you want to err in favor of the patient, just call it in. But the what we'll do with the non-Q wave thing is if there's enough suspicion, the cardiologist will probably take that one to the cath lab, and certainly if their enzymes bump, they'll take them to the cath lab anyway. But not as a acute STEMI. Usually it's usually an hour or two or three while we evaluate enzymes and things like that. 2/3 of cases present as NSTEMIs to start with. Now, as you know, the orders are that if you're having a patient who continues to have chest pain, I want repeated 12 leads. We often have this go from an NSTEMI to an actual STEMI over a period of 2 or 3 or 4 12 leads. So, looking at an inferior MI, evolving STT changes in leads 2, 3, and AVF. So you've got nice ST segments in 2, 3, and AVF. Looking across here, you've got a little sag, a little what would have been called ischemia in lead 1 and AVL. So those are the reciprocals. You say, well, gee, do I have reciprocals here? Well, maybe, but you can't always bet on that. But you've got enough to say, I've got ST segment elevation in 2, 3, and AVF, and I've got reciprocal changes. So here's another nice example, ST segment changes. You've got reciprocal changes in 1 and AVL. Really some nice sags out here too. So good ischemia. You don't have any problem calling that one a STEMI. No one will argue with that one. This is what happens when it's fully developed, when we don't treat it, when we don't take care of it. Now, after 2 weeks, this person has significant Q waves in those leads, and the ST segments, he's got a little T wave inversion now, but the ST segment is pretty well coming down to normal. That's an evolving, devolving STEMI. And that's too bad. There's heart muscle damage, and that person will probably have a decreased ejection fraction now. Now, with the STEMI, probably up to 50% of with an inferior STEMI, probably up to 50% of the patients that involves the right coronary. The right coronary artery serves the right side of the heart, and only 50% of the time. So, in that case, what's the rule? The order? The order is to determine whether this is a right coronary infarction, because if it's a right coronary infarction, that means that the right ventricle is affected, and it's going to be very much dependent on preload to keep your blood pressure going, because it's a very weak side of the heart anyway. Low pressure system, pulmonary system. So if it's damaged and it won't be able to pump forward as efficiently, it needs primer. It needs to have fluid for pump. You can't disappear your fluid into the venous system. And how do we do that? We disappear the fluid into the venous system by giving patients nitroglycerin, which dilates the venous system, makes a great capacitance, but then blood doesn't return to the right heart, and the heart can't compensate for that. So in a right-sided MI, a STEMI, inferior STEMI with a right-sided MI, right coronary MI, that means that if you drop the person's blood pressure, vasodilate them at all, you're really going to plummet their blood pressure. And those are the guys that get into real trouble when we give them nitroglycerin. How do you could just not give nitroglycerin, or you can do a right-sided 12 lead, which means just move V3 and V4 to V3R, V4R. And I'd really like you to get both V3R and V4R. It takes almost no difference of time to do that. And then if you get ST segment elevation in V3 and V4, along with the elevation in inferiors, then you know that that's a right coronary infarct. And what you have to do with that is just not give them nitro, unless they're frankly remarkably hypertensive, and that happens occasionally. So, but if a patient has a right-sided MI and they have a blood pressure of 190 over 110, I think I'd like to lower that pressure anyway, that'd be better for their heart. So you can give them nitro in that case. But if they're normotensive, don't give them nitro. Give them something else for pain, like fentanyl, which doesn't drop your blood pressure. So the reason we went away from morphine for chest pain is because morphine will always vasodilate and drop your blood pressure because of the histaminic effects of morphine. So I didn't like that. And the studies show that there's a higher morbidity and mortality with using morphine in MIs for that very reason. Now, an anteroseptal MI. Your ST segment elevation is going to be in the anterior leads, V1 through V3, V2, V3, and often V4. So you've got ST segment elevation, you got a little bit in the septal, which is truly V1, but this is still septal V2, and anterior, so you ST segment elevation, and ST segment elevation out here. Also got a little bit in V5 and V6, which is going to be a lateral. So here's anterior changes, strict anterior, but V1 is pretty well spared, but look at these guys. These are nasty ST segment elevations, and you've also got some in V1 and in AVL. Remember, those are the lateral. So this is actually going to be an anterior lateral MI. What happens when the anterior MI evolves? Well, you get the Q waves in these big leads, and so now this is fairly wide, and you can say, well, how do I know that that's not a left bundle branch block? Well, because it carries all the way through there, and you have nothing in V6. You have a Q wave, but it turns out if you measure it, it's right on the cusp. It's by 0.11. It's not wide enough to be a bundle branch block, but it's close to that. But it's a big Q wave, and that's what we don't want to see happen to that person. If you get an anterior MI with big Q waves, you can guarantee that ejection fraction is not very good, because anterior MI means it's in the left heart, and the left heart is your big pump. And you damage the left heart, you damage your ability to pump forward. Anterolaterals, so you've got anterior. Got ST segment elevations now in V5 and V6, also some in 1 and in AVL, so it's a pure anterior lateral. This is what happens. You get your Q waves in the lateral chest wall as it evolves. high lateral, mostly involving 1 and AVL. Now, a true posterior MI. Your EKG changes are in V1 or V3, but they're basically a mirror image of an anterior septal MI. So, a couple cardiologists I knew at one time said, well, the best way to see this is to take your EKG and hold it up to a mirror, and if it looks like it's ST segment elevation in the mirror, I said, that's the silliest thing I've ever heard. You can't go walking around with a mirror in. But basically, so what you're seeing is extreme, what appears to be a pretty good sized R wave, and then ischemia. And the same thing in V2, big R wave and ischemia, but what you're really looking at is ST segment elevation upside down and backward. And you say, well, how can I figure that one out? Well, the guy's got chest pain, and the nice thing about this is most of the time it's associated with ST segment elevation in the inferior leads. So here you have 2 in AVF elevated. So you say, inferior. What this is the reciprocal. So this is really, but if you call it an inferior MI or if you call it a posterior MI with reciprocal changes, what difference does it make? This is an inferior MI and posterior. It's a posterior MI. You're going to treat the patient the same way. You seldom will see significant changes in here without seeing some changes in, how often, maybe 1 out of 50 in my guesstimate, that you will see only posterior changes. Now, in the long run, what happens when that MI fully develops after 2 weeks? If you missed it, if we don't treat it, well, instead of getting a Q wave, you get a huge R wave in V1, which is not right. Your R wave should be tiny in V1 and then gradually progress into V1 and V3 or V2 and V3. The R wave gets bigger as you go through the V leads, not a giant R wave that's fairly wave. This is a Q wave, so put that to the mirror, and it's a Q wave. So, know what to look for. ST segment elevation, more than 1 millimeter in 2 contiguous leads, not in lead 1 and lead AVF. Those aren't contiguous leads. It's 1 and AVL. Know where you're looking. So use your pocket card if you can't remember it, but it's pretty straightforward. 2, 3, and AVF go together. That's inferior. 1 and AVL go together. That's high lateral. V1, V2, V3, V4 basically go together as anteroseptal. V5 and V6 goes together. It's lateral. Okay, STEMI mimickers, the kind of things that we don't want to call in as a STEMI because they're not STEMIs. First one, we already mentioned briefly, acute pericarditis. In acute pericarditis, you see ST segment elevation in more leads than you should. In other words, most leads. And of course, if you have, so here you have lead 1, lead AVL elevated, lead 2, 3, not so much elevated, but lead AVF elevated. You have elevation in V1, V2, V3, V4, V5, V6. So this person is having a total body, total myocardial infarction. No, that's not going to happen. You're not going to occlude both the right and left coronary, all segments at the same time. So this is, and then the symptoms, what are the symptoms of pericarditis? They complain of pain, but it's not crushing substernal pain. It's usually pain with, at worst with a deep breath, or with swallowing, or with bending over. They may have a fever. It's an inflammatory process. Is it infectious? Possibly. And it's not, and then you have ST segment elevation in too many segments to be realistically a myocardial infarction. Big one, which we see, and think mostly of older people, people who have a history of chronic hypertension, history of their cardiac disease. They get left ventricular hypertrophy. And what catches your eye right off the bat is that their R waves are really big, or their S waves are really big, or all of them, the R waves and the S waves in the V leads, the chest leads, are very big. They're actually bigger in the limb leads too, but they're particularly big in the chest leads, because those are the ones that are right on top of the left ventricle. So what you do, the rule is, you take the largest deflection of V1, which is an S wave, largest deflection, count it out, and add it to the R wave in V5, or the S wave in V2 and add it to the R wave in V6. And if it's more than 35 little boxes total, that's by definition left ventricular hypertrophy. And it could be wide complex, it could be narrow complex. In other words, QRS could be wide or narrow. In this case, it's narrow, which is more often than wide, but it doesn't make any difference. So it's the height of the R of the S wave and the height of the R wave put together. So V1 and V5 go together, V2 and V6 go together. So in this case, we'll look at V1, and you have each of these big boxes is 5 little boxes. So you have 1, 2, 3, 4, 5, 6, 7. Well, you're already over 35. But then you add this one, and so you've got 1, 2, 3, 4, 5, and another 25. You've got a lot. That one's not hard. So, and you notice that in V1, you have ST segment elevation. That doesn't count. That's the mimicker. You're going to have ST segment elevation in the presence of left ventricular hypertrophy. So all of these ST segment elevations, although they're there, you can't say that's a STEMI. You have to say that's left ventricular hypertrophy. Patient may have chest pain. It may look like it, but don't call that as a STEMI. If you want to send it in on your Pulsera, you say, I got chest pain, and here's the 12 lead. I think this is left ventricular hypertrophy. We'll let Marty sort it out. Now, MI and a right bundle branch block. Remember, the right bundle branch block has your terminal R wave is upright in V1. So here you have an R wave, and there's actually there's a Q R prime here. very tight, but, and you say, well, this is a nice right bundle branch block. And you're looking around for now, well, that's not ST segment, that's not, ooh, this is now beginning to be a little ST segment elevation. And there we've got some nice ST segment elevation in here, and these are contiguous leads, and there's ST segment elevation here. And with a right bundle branch block, the ST segment elevation counts. So this one you can say is a right bundle branch block with acute ST segment elevation. This is a STEMI. So this is not a mimicker. This is a real STEMI. It's a right bundle branch block with ST segment elevation. Here's another one showing ST segment elevation here with a right bundle branch block, wide complex, R, terminal R wave upright. And you've got ST segment elevation here, you got ST segment elevation here. I would call that one too. But now you've got the most common. Now right bundle branch is not as common as left bundle branch. We see a lot of left bundle branch blocks. A lot of them happen after a STEMI. A lot of them happen during a STEMI. But by and large, the left bundle branch blocks we can't call, because they're always going to have some ST segment elevation. So this is a left bundle branch block, correct? Wide complex, deep R wave or S wave in V1. You want to look over here, it's a little wide down here too, and if there's anything, there's a little rabbit ear notch at the top that's an R prime in V6, but that's not necessary. All you need is V1. Right bundle branch block, and it looks like there's ST segment elevation, but it's not real. And you say, well, look, there's ST segment depression in these leads. Yes, but ST segment depression and the R wave has to be in concordance to make it real. Concordance means your ST segment elevation is present when you have an upright R wave as well. So in the V lead or a V1, you have an S wave, and the ST segment elevation is discordant. It's upright, whereas this is downward. In this one, the R wave is upright, but the ST segment is somewhat depressed. It's not concordant. It's in the wrong direction. The same as this one. R wave is up, ST segment is depressed. There's no ST segment elevation where there's an upright R wave. And that is the definition of concordance in a left bundle branch block. So here's another nice left bundle branch block. ST segment elevation there, it doesn't count, it's the wrong direction. You don't have any place in here where you have concordance. So left bundle branch block, and if you're not comfortable with concordance, just don't call a STEMI with left bundle branch block. How often will you see concordance? Well, I say in the last 5 years, we've got 2 cases of concordance in all of the left bundle branch blocks we've called in. And that's probably 300-400 of them. It's not common. So unless you're absolutely convinced this is enough, call it in what it is. I've got a guy with chest pain, and he's got a left bundle branch block. That's all you have to say. If you want to send the picture by the Pulsera, that's even better. Let the ED doc sort it out. Discordance is normal in the left bundle branch block. Concordance is not normal, and it's very uncommon. Okay, here's a,
Glenn, can I say one?
yeah,
So one of the advantages we have is we have access to all the old EKGs and a lot of these patients, especially the old ones that have had previous interventions. So it's very helpful to have that and be able to compare it to, because you guys don't have that luxury. And so we can make more definitive calls based on what we're seeing on a particular complex patient like some of these examples. In order for us to do that, though, we need patient information. So if you snap a photo of their ID card with their name that's accurately spelled, reference to, it's extremely helpful. And it can help us, be more accurate with activating the cath lab. So that's greatly appreciated.
so benign early repolarization is an EKG pattern that's commonly seen in young persons and in healthy people less than 50. Unfortunately, occasionally you see it in an unhealthy person under 50 as well. But it's widespread ST elevation, not as much as in pericarditis. It's very common in the precordial leads, so in the V2 through V5 leads, and it's can be confusing when patients are having symptoms, particularly I think, oh, I have heartburn. Well, it probably turns out to be heartburn, and then they have this little ST segment elevation in the 2, 3, 4. What you often see is a little notching at the J point. The J point is where your ST segment begins. So by the S and T, so right at this level here, you often get this little notch. And you can just see the little notch as it occurs in this. So in this one, for example, you've got in lead 2 here, you've got a notch, little ditzel here. Same thing in 3, little ditzel. This one is fairly clean in V1 and V3. So, but now in V4, you've got another little ditzel. So this is a J-point notching, and this is, although we have ST segment elevation, slight ST segment elevation, you might say, oh, is this a inferior MI? It's probably benign early repolarization. Now, a ventricular aneurysm. I was talking with one of you at the break and asked, well, what happens if you have a full thickness MI? How come the tissue just doesn't, when it's dead, why doesn't it just rot? Well, it doesn't. That's not the way things work when they're. First of all, you still have some minimal perfusion of that tissue through the endocardium and the epicardium, but you get, what happens is that normally it scars. What the Q wave is a scar. Unless, and the scar is pretty strong. I mean, it's strong, but it doesn't contract. Now, sometimes, instead of making depending on the size of the injury, instead of making a fully developed scar, this tissue gets weak and thinned, and because it has increasing pressure on it, and the tissue around it is contracting and pulling on it, it stretches and thins out, and then because you've got blood inside the ventricle, it begins to balloon out because it becomes weak, and it makes what's called the ventricular aneurysm, which is basically a bleb, a ballooning out of the ventricle. The bleb doesn't, because the tissue has been injured and killed, it doesn't contract, and it's dyskinetic. It's sort of like how a flail chest works. You know, when you have the flail chest and when you breathe in, instead of having your chest rise out, it sinks in. Well, as the heart beats, the ventricular aneurysm balloons out. It's disconnect, so that the heart function, the muscle function, it doesn't function very well, and the EKG looks different, and it has a potential for possibly rupturing in the future. It's usually held in by the pericardial sac, so that kind of keeps some of that together. But the trick with the ventricular aneurysm, it ultimately will mimic a STEMI, because when you do a 12 lead of it, it will show persistent ST elevation, because that ballooned out aneurysm doesn't conduct and doesn't function like the rest of the heart. It doesn't necessarily show the Q wave. It can show the Q wave if there was enough scarring there too. It can occur in any lead. It's most common in V1 and V4 because those are the big ventricular leads anyway. Patient has to have a history of a transmural infarct, in other words, a STEMI. And this is what it looks like. You get, in this case, narrow complex, big Q wave, but a narrow complex, so this is a Q wave now. Q wave, Q wave, Q wave, but persisting ST segment elevation. Now, you say, well, if the guy just had a STEMI a year ago, and now he's having severe chest pain, could he have a STEMI with ST segment elevation from an acute heart attack? Probably, yes. That could happen. If he had a normal EKG in between, it'd be nice, or a EKG just showing a Q wave. But in this case, if this occurs like 4 weeks after if you go out 4 weeks after his myocardial infarction and he still has ST segment elevation, it's probably a ventricular aneurysm. Now, if the guy's having chest pain and he's having this, unless you had seen him previously 2 weeks before, I would probably call them as a STEMI and let them worry about it. Because it's probably just as likely that he's had another myocardial infarction as he has an aneurysm. And it doesn't hurt us any for you to send the picture in by the Pulsara. Okay, what are our treatment guidelines in your orders for STEMI? Well, this one where is this assumed STEMI? Well, it's V1, V2, V3, V4, V5, V6, AVL, little bit in one, enough to think about, and reciprocal changes. So I guess we could say this is a big anterolateral, a nasty one. Those are tombstone-y looking kind of things. So I think we'll call that one as a STEMI. Your initial intervention, primary survey, O2 high flow. I want to keep your oxygen at it should say 94 to 98. EKG, treat any dysrhythmias per protocol. If ischemic event, get a 12 lead. Don't delay care. IV nitroglycerin, repeated every 3 to 5 minutes. but a caution in right-sided myocardial infarction. So what I said is if you have a proven right-sided myocardial infarction with ischemia in inferior leads with a positive V3, V4, right V3, V4, I want you to withhold nitro unless the patient's hypertensive. Go right to fentanyl for pain. Aspirin, everybody gets an aspirin. You guys are doing really good. I don't think I've seen a single miss of aspirin. And we're giving, actually, we have to change this one. We're giving, at the request of the cardiologist, they wanted to see 4 baby aspirin, so they wanted to see 320 milligrams of aspirin given. So a STEMI, active chest pain less than 12 hours, 12 lead EKG with ST elevation 1 millimeter or more, no left bundle branch block or paced rhythm. Paced rhythm, of course, is going to be a left bundle branch block. Unless you have concordance in 1 or more lead. No active bleeding, severe liver failure, severe systemic disease. We won't send that one probably to the cath lab. Notify the ED immediately. Do aspirin, nitroglycerin as indicated. Transport initially. If your initial 12 lead is negative or inconclusive, repeat every 3 to 5 minutes if symptoms persist. Do a V3 and V4R if you have inferior MI. So, any confusion? I want to talk a little bit about dysrhythms, which is not MI. Dysrhythm may occur with an MI, but okay. Ventricular tachycardia. Usual causes are ischemic heart disease, cardiomyopathies, structural disorders, previous surgical scar, drugs that prolong the QT interval, so class 1A and class 3 antidysrhythmics, things like amiodarone, things like procainamide, things like pronestal, things like brain is just having a shutdown here. Also drugs, a lot of drugs prolong the QT interval, phenothiazines, including Haldol, etc. Which is why when you use Haldol and things, I want people on a monitor, because you can see if they do something funny then. Methadone will actually prolong the QT. We've had now, in the last 4 years, we've had 5 kids, teenagers with sudden cardiac arrest, which are all basically from essentially long QT syndromes, and they're congenital, and they end up with internal cardiac defibrillator. Electrolyte imbalances, hypokalemia, hypocalcemia, hypomagnesemia. Anybody who is in a starvation kind of syndrome, or who's on electrolyte wasting medications, certain diuretics, people who are excessively dieting, people who have been bulimics, anorectics, alcoholics. Essentially, alcoholics are sort of in a starvation syndrome. They're often low on magnesium and potassium, calcium. This is why they have seizures sometimes, and if they have a seizure, They probably also have prolonged QT. Digitalis toxicity. So, ventricular tachycardia, and this one kind of is suspicious of, especially particularly in lead 2, a nice line, it's kind of suspicious of being a torsades kind of thing because it's kind of moving, it's various and sundry. It looks like it's moving around a point, like torsades does. Rates greater than 120, QRS greater than 120, so 3 boxes. If there's a P wave associated, there's no AV, there's no relationship between the ventricular rhythm, and it can be polymorphic or monomorphic. If it's polymorphic, it's likely to be more of a torsades. Treatment of ventricular tachycardia is very straightforward. If it's unstable, so unstable by definition, hypotensive, signs of congestive failure, chest pain, shortness of breath, confusion, or being unconscious. That's unstable. If they're conscious, if you can, give them some Versed to start with, but sync cardiovert them. If they're uncardioverted, they just get sync cardiovert. If they're unconscious, sync cardiovert them. Start at 100, 150, 200. We had a case the other day that was cardioverted in the ED at 200 directly. If you forget the 100, 200, 300, I'm not going to spank you, just sync cardiovert them. Unstable. If they're recurrent VTAC or persistent VTAC, treat with amiodarone or magnesium sulfate. If the patient appears to be a torsades, the first drug of choice would be magnesium. If they appear to be just a regular VTAC that didn't convert with shocking, give it a dose of amiodarone and repeat the shock. If ventricular tachycardia is stable with adequate perfusion, if they're stable, you have time. Do a 12 lead prior to and after treatment. Now, you notice you didn't do a 12 lead with an unstable patient. By definition, they're unstable. You don't have time. If they're stable, treat them with amiodarone, 150 milligrams over 10 minutes. You can repeat that if VTAC recurs or didn't go away, and they still stay stable. Now, if they stay refractory, or if they go into torsades, or if they happen to be a tricyclic overdose, give them some magnesium. If VTAC persists, call them unstable and cardiovert. Now, if the patient is totally stable and you say, God, I don't know if I want to do this, call and talk to medical control. Because sometimes we will transport, if you've done multi-treatments and they still stay in VTAC, there's something else going on. And if they're stable, they're stable. If the patient's unstable, or you think, if you smell unstable happening, just call them unstable and cardiovert them. Now, if in your cardioversion they convert to VFib, you immediately switch over to the VFib mode and defibrillate them. If the VTAC is pulseless and the patient is unconscious, not responsive, then you treat it just like VFib and you defibrillate rather than cardiovert. This is straightforward. Only cardiovert somebody with a pulse. Defibrillate otherwise. Okay, wide complex tachycardia. This confuses us a lot. Definition wide complex tachycardia is almost the same as VFib or VTAC in the sense that it's greater than 120, so more than 3 little boxes. Rate of tachycardia has to be over 100. The differential of wide complex tachycardia could be ventricular tachycardia, and if you think it's ventricular tachycardia, treat it like ventricular tachycardia. If it's unstable, treat it as unstable. It's the same treatment. Shock. So it could be the differential is ventricular tachycardia or supraventricular tachycardia with aberrancy or pacemaker rhythms. And you should be able to pick out a pacemaker rhythm. First of all, the guy's got a lump on his chest. Secondly, you've got the spike. You should be able to pick that out. And they're all going to be wide complex. Most of them are going to be left bundle branch block type of pattern. Because, why is it a left bundle branch pattern? Because the pacemaker implant goes into the right ventricle. So the right ventricle depolarizes first, and then the left ventricle depolarizes, going around the heart. So it becomes a left bundle branch pattern, wide, complex. Hey, where is that? Your S wave, the big deep S wave, is going to be mostly in V1 and V2. Makes sense. Maybe all the way across the chest. So, how do you distinguish between supraventricular versus ventricular? Well, there's no reliable way of doing it, but there's a couple things that make one or more likely than the other. Specifically, for ventricular tachycardia, a history. It's more likely ventricular tachycardia if they have no prior history of having a tachydysrhythm. So if somebody says, yeah, I often flip into this rapid rhythm, and you look at the 12 lead and it's a wide complex tachycardia, either regular or irregular, and they say, oh yeah, I get this before and I've had to be cardioverted before, then that's probably, that's probably going to be supraventricular tachycardia because it's occurred before. So if this is their first trip of wide complex tachycardia, it tends to be more likely ventricular tachycardia. If they have a history of structural cardiac disease, such as a myocardopathy, hypertrophic myocardiopathy, then that also predisposes to ventricular tachycardia. If they have a pacemaker or internal cardiac defibrillator on already, it's probably a good bet that it was ventricular tachycardia. And their pacemaker ICD is just not working now. Supraventricular tachycardia, if they have a history of previous SVTs. I mean, you go out there a whole bunch of times to see people. There's a lady out in the Yakulty area that wants to get, she wants to get adenocard all the time, and she won't go see her doctor. She knows she has supraventricular, but it's too much trouble to go in to see her doctor to get something taken care of. She's got a history, so it's your history given. Examination, ventricular tachycardia is favored if the patient's unstable. Well, you're going to go ahead and treat it as unstable then. If there's cardiac failure, by and large, supraventricular tachycardias usually are perfusing. The patient's awake. They may be complaining of things, but they're perfusing. If they've had a previous sternotomy scar or pacemaker and ICD, et cetera, they probably are ventricular tachycardia. Ventricular tachycardia is more common in wide complex than supraventricular, but so 80% of the patients we see with wide complex tachycardias are probably ventricular tachycardia. More likely, ventricular tachycardia with extreme right axis. So this is the only thing that you might pay attention to the axis on, is if you're trying to determine is this VTAC or supraventricular tach, if they have extreme right axis, so down in V1 and down in AVF, extreme right axis, it's probably ventricular tachycardia rather than supraventricular tachycardia. SVT is more likely if the rate's exactly 150 or way over 200. And if it's a narrower QRS, so the width is barely wide enough to count as a wide complex. Now, wide complex tachycardia, uncertain type, but you think it's supraventricular. If it's stable and regular and monomorphic, means there's no polymorphic characteristic of the QRSs. Stable, regular, and monomorphic. Heart Association says if you think it's supraventricular or probably supraventricular, stable, regular, monomorphic, and your gut level is it's supraventricular, then you can try adenosine. 6 milligrams, you can repeat the 12 milligram dose. If, however, you ask the patient in your history, if they say, yeah, the doc says I have that funny WPW thing, or if you can find delta waves on your delta waves, a little upslurring that you get with WPW, a little upslurring of the QR. The P wave appears to be, the PR interval appears to be very short because there's a real slur into the R wave. That's a delta wave. That's indicative or suggestive of WPW or reentry tachycardia. Don't use adenocard if you have known WPW or delta. Treat this as if it's VTAC. And a stable VTAC you would treat with amiodarone for a wide complex, stable VTAC. If you've treated with adenocard, then go ahead and treat the patient, and they didn't convert, go ahead and treat the patient as if it's VTAC then. And if you would then give them amiodarone, fine, if they're stable. If they're unstable, if at any point the WCT becomes unstable, say they're unstable and treat them with Dr. Edison's favorite medicine, which is electricity. Now, atrial flutter. Atrial flutter typically has a large reentrant circuit. So it's a supraventricular tachycardia, but it may present as a wide complex too. But supraventricular with atrial flutter, if it's a narrow complex, the rate is usually 250 to 350, so it's pretty fast. And so you kind of know that it has to be. A ventricular rhythm usually is somewhere between 120 and maybe 180. If it goes over 200, you're starting to push the envelope. Because the ventricle just can't beat that fast without being driven by a source above it. So usually the beats, there's a 2-to-1 block, so you get a regular rhythm of maybe, if the underlying rhythm is 300, give or take, so if you have a 2-to-1 block, you have a rate of 150, which may ultimately involve the patient fatiguing out, getting short of breath, getting signs of congestive failure, getting maybe some chest discomfort from ischemia, because there's not enough filling time and there's no absolute coordination of the atrium and ventricle. If it's a 3-to-1 block, then they'll have a rate of 100, and the patient's pretty stable. I mean, totally stable at that level. You don't have to worry about it usually. If it's a variable block, 2-to-1, 3-to-1, then the rate's going to be okay at, maybe 120. Once again, you may not have to treat that at all, just transport them. If it's a 4-to-1 block, and your underlying rhythm at the atria is 300, then the rate's only going to be about 75, which is still okay. So, here's a couple of variable rhythms. Here is a atrial flutter with a 2-to-1 block. Here's an atrial flutter with a 4-to-1 block. Here's an atrial flutter with a variable block. But this patient might be short, if it's an older person, this patient might be short of breath, might be worth treating. This patient, probably not. Just start a line, keep an eye on them, and transport them. Atrial fibrillation, my favorite of all. Most common sustained dysrhythmia. Basically, it's disorganized atrial activity, so you have an irregularity of the ventricular response. Because the atria is fibrillating, be a variable block at the AV node, and so some of the atrial beats will get through, but totally variable. So your ultimate rhythm is an irregularity. You can hear it better than seeing it. If it's really fast, you can hear so listen to the machine beeping. It may be acute, may be transient, may be paroxysmal. Some people start and stop. You get there, they'll be whipping along in atrial fibrillation with a rapid ventricular rhythm and then spontaneously kick out of it. They may be stable, they may be unstable. Has multiple causes, potentially causes of it, but the most common is age and ischemic changes and atherosclerotic changes. The incidence is prevailing. The lifetime risk for people over the age of 40 years of age is 25% of us will get atrial fibrillation before we die. No, not that many of us will die of atrial fibrillation, but we'll have atrial fibrillation. Atrial fibrillation is a common occurrence post-cardiac surgery, usually occurring about day 2 or 3, goes away. So here we have atrial fibrillation with a rapid ventricular response. Best thing is look at your lead 2 or your rhythm strip lead, and you can see that it is irregularly irregular. Now, do you need to treat that? Only if the patient is symptomatic. Why would this patient, as you get old, with the atria and the ventricle being not in sync, remember the atria gives a little push of blood into the ventricle just before systole. That's what the AV node is there, is to slow things down so the atria can make a contraction, giving just a few cc's of blood push into the ventricle, which stretches it at the end of diastole, which gives it extra power with no work. That's called the Starling effect, the Starling mechanism. It's a stretch, it's that little stretch that you do of the muscle and gives it more power with no extra work. When you lose that, you lose about 15% of your cardiac output, which may be enough to push an old person into congestive failure, into ischemic pain in their heart. But, I mean, most of us can get along fine with heart rates. How fast is this heart beating? Oh, varies, maybe 150, 160 times a minute, the ventricle beat. You know, that's a good run or a good ride on a bike. Most of us can do that without any trouble. So even older persons, but atrial fibrillation, losing that little kick, may kick them over. So they may be symptomatic. Treatment of atrial fib or flutter with no hypotension, with a rapid ventricular rate, symptomatic. If they're symptomatic, in other words, they are starting to get chest pain, or they're complaining of chest pain, they're having some signs of congestive failure, RALS, it's affecting their mentation a little bit, we can slow that rate down. We'll slow the rate down. We're not treating atrial fibrillation. There's nothing in your orders that says treat atrial fibrillation. I don't want you to treat atrial fibrillation. Atrial fibrillation, if I'm going to treat it and cardiovert it, I do a lot of, except if the patient's very unstable, you have to do some really significant tests on the patient, including, now we do an ultrasound to see if they have any clot on the leaflets of particularly their mitral valve, because if you cardiovert them, and whether it's electrical or chemical, and they suddenly change to a regular sinus rhythm, they blow some of those clot off, and that can stroke a patient, that can, affect, you can get a clot into a kidney, you can get a clot into, rarely into the heart itself, into coronary artery, you can get a clot down a leg. There are downsides of cardiovert. So we don't, in the field, treat atrial fibrillation except unstable. But what we do is slow down the rate if the patient can benefit from that. We slow it down with the drug of choice is diltiazem. Slow. 0.25 milligram per kilo with a max. I put a max of 20 on it the first time around. And you can repeat it as needed, but you probably won't have to ever repeat it. If we don't have diltiazem, verapamil works. It's a little bit different dosage. Usually it's 5 milligrams over 2 to 3 minutes. Now, often when you use verapamil, and sometimes when you use diltiazem, they drop their blood pressure. Then we treat the patient with some calcium. These are calcium channel blockers. So we give them some calcium, and the best way is to give this stuff slow in the first place. Now, there's a caution. If the patient's taking beta blockers, the combination of a beta blocker and a calcium channel blocker, I will guarantee will drop their blood pressure. So we usually don't do it. And also, only use diltiazem, calcium channel blocker, just like adenosine. Don't use it on take that back. Do not use diltiazem, calcium channel blocker, or a beta blocker if we were using that, but don't use it on a wide complex tachycardia, because you cannot sort that out if that is a WPW or not. And that can give you a reentry only through the alternate pathway, and you could end up with a reentry VTAC. So we don't use diltiazem on a wide complex tachycardia. Very simple. Narrow complex with symptomatic symptoms if you're trying to slow the rate only, if you think there'd be some guarantee there or some advantage. If you have hypotension, calcium gluconate IV plus a little fluids usually does the trick. Now, obviously you can't use fluids if the patient's in congestive failure. So, here's the supraventricular tachycardia, fairly wide, but not wide enough to be wide complex. And if the patient's symptomatic, then I would go ahead and treat it. Now, atrial fibrillation, if it's unstable with a rapid complex, cardiovert. Now, you said, well, wait a minute, you just said that you don't cardiovert atrial fibrillation without doing some tests. Yeah, you cardiovert doing some tests. Yeah, you cardiovert it if it's unstable. Unstable is unstable is unstable. Unstable means hypotension, shock, severe chest pain, severe congestive failure, altered level of consciousness. That one gets shocked. PSVT, abrupt onset and termination normally. QRS complexes are usually narrow, usually a reentry. Treatment, we do vagal maneuvers first. If that doesn't work, try adenocard. Vagal maneuver, we're now using, and a lot of you are using vagal maneuvers besides having them blow into the syringe, which is a good trick, is that have them do the vagal maneuver laying down and then elevate their feet immediately, their legs. So that's an augmented vagal maneuver. You're returning blood from the legs, and that stimulates the vagus even more. And that will usually cardiovert them or convert them. Adenocard, the dose is 6, 12, and 12. Most people convert by the time you use the first 12 dose. Most people convert with 6. Now, patients who've done this, like the lady I was telling you about in the echo there, she knows what dose works for her. Says, I want 12 right off the bat. Most of the time, and we did this study long ago, the 6 milligram converted most 85, 88% of the people converted on 6 milligrams if you gave it fast enough. Caution for PSVT is and adenocard is asthma, pregnancy, patients who are on Tegretol, which is anti-seizure meds, or dipyridamole, which is a antiplatelet medication. It's not so much contraindicated in AFib or a flutter as it doesn't work. What it will do often is slow down the rhythm so you can see that it's AFib or a flutter, and then it'll speed back up again, and it won't change. It's not so much it's contraindicated, it just doesn't work, so why waste your time unless you're doing it for that diagnostic advantage. WPW. If the patient with PSVT is unstable, what do? Spark them. Now, if it's pure PSVT and you've done vagal maneuvers, you've done full dose of adenocard, and incidentally, one of the things to try after you use adenocard, if say you've used 2 doses and it hasn't changed the patient at all, hasn't converted the patient, do your vagal maneuver again. That'll often kick them over. But if PSVT persists and the patient is stable but whining and complaining about it, you can do a calcium channel blocker then. And the dose is standard diltiazem dose, 0.25 milligram per kilo, slowly, and it will probably do the trick. Now, remember, it'll at least slow the rate down. Don't use it on any wide complex tachycardias. Okay, somewhere here I have some, where do you have those listed? Oh, right-hand side. Okay. All right. We have some case reviews. Okay. First one, chest pain, clammy, 63-year-old female. About 9 a.m. had an onset of heartburn-style chest pain moving from xiphoid up to her throat, causing numbness in her left arm, sweaty, short of breath on exertion. Took multiple gas pills with no relief. Has never had this before. Standing outside a trailer. Had just seen I, Tonya. Speaking in full sentences, no immediate distress, moved to the gurney. So GCS is fine, of course. Pulse ox 98. Impression suspected inferior STEMI on the 12 lead. So here we have ST segment elevation in 2, 3, and AVF. And we have, notice this one, they didn't mark it, but you see the before here is a nice big R wave. So when we go to the next one, oh, there's no R wave there, so that happens to be a V4R. I just didn't write it down on the thing. So you've got ST segment elevation, and you've got some minor ST segment elevation here. Now, happily, they appear to have done maybe a V3R here, so that it looks elevated too. So this is, I don't know that they necessarily called that one as a right-sided. Let's see if they did any, let's see. Okay. I know this one got aspirin, inferior MI, and this was a positive right. So this is a positive right side. They did the right side exactly what this lady went to the cath lab. She had a 99% occlusion. I don't know how you can tell 99 versus 100% occlusion. Must have been maybe one red cell getting through at a time. And it was in the right, the mid right coronary artery stent. They ballooned it, put in a stent. She had what's called TIMI 3 flow, which means normal flow, immediately, and she left the hospital literally the next day in perfectly good shape. Had no problem with her ejection fractions. Perfect result. She'll be good for another 25 years. Priority 1 for a 70-year-old with chest pain. Getting ready for dinner, suddenly had chest pain, pain in the center of the chest, nausea, dizzy, clammy, took some blood pressure medication, the pain subsided momentarily, didn't say what the blood pressure medications were. Although amlodipine and things like that work for, are often given for, which is a calcium channel blocker, are often given for angina. Past medical history of a previous MI, pains 8 of 10. Okay, well now this is her first, that's kind of ticking along there. Yeah. Blood pressure is 103/68. SpO2 is 25. EKG is a kind of a wide complex tachycardia. Now, is she stable or not stable? She's got chest pain. Here's her 12 lead. She got aspirin. And she has a pulse. She's talking to you. She's sitting there. So what is our diagnosis of this likely to be? Is it supraventricular or ventricular? Setting of chest pain, setting of previous MI, setting of, let's see, she's monomorphic, regular. I think I'm going to call her VTAC, though. Be on the safe side. But then she did this. She did this all by herself. This is why we want you to have, copies of the 12 lead to give to, and copies of your rhythm strips to give to the ED and to give to the cardiologist. Now, interesting in this one, the somewhere between the ED doc and the cardiologist, the 12 lead and the rhythm strips were misplaced. So the cardiologist said, well, I can't tell if this is really VTAC or what it was. Well, they hunted around to get all the stuff, and they finally found it. But that's not your problem. You have to leave those things with them, but you can't find. So this was a spontaneous conversion, just self-converted to this irregular rhythm. She had past history, it turns out, of atrial fibrillation. And so she irregular rhythm with PVCs. Her rate's about 94. Chest pain dropped to 3 of 10. Got some nitroglycerin. Went to the hospital. EKG is irregular with PVCs. EKG is probably irregularly irregular. It's either atrial fib or something akin to that. I don't see any good P waves in it. Whenever I can't find P waves and it's irregular, I'm going to call it AFib. Heart rate stayed around 100. Blood pressure is 126. She's pretty stable. And this is what she looked at later. And so this is her next set of 12 leads. And then she had this irregular bigeminal kind of pattern, which is either, but I don't really see a very good P waves in there. So is this an odd atrial fibrillation or an atrial flutter underlying it or whatever? It doesn't make any difference really for us. In the hospital, question is, and that's what they kept saying, was this AFib with rapid ventricular response versus VTAC? On admission, she had a left bundle branch block but 2 hours later, she had no left bundle branch block. She also had a slight bump in her troponin, so they ultimately called her an NSTEMI. She went to, troponin is the enzyme we're testing for. So they called her an NSTEMI. She ultimately went to the cath lab, had no lesions. Her EKG was pretty rapid for VTAC, but not impossible. And I think the cardiologists are giving her the choice. I believe she's a Kaiser patient, but they're going to give her a choice whether she wants an AICD or not, an internal defibrillator. She will probably say, hey, I just call Camus. That works out for me. Okay, 57-year-old patient in cardiac arrest. Patient watching TV, head rolled back, went unresponsive apneic. Daughter was instructed by dispatch to start compressions for about 5 minutes. On arrival, patient in the living room, CPR continued by fire. Shocked once, no meds were given, had BVM with an OPA. Another 2 minutes of CPR rhythm check was an organized rhythm with a radial pulse. Total ALS CPR is approximately 4 to 5 minutes. ALS CPR. Patient loaded the gurney, transport limited, was initiated. 12 lead, had narrow QRS complexes, a rate of 100 with no obvious ST segment elevation. Intubated on the second attempt, good capnography and waveform. So started out VFib, defibbed, got an IO in the right humeral head, correct place for it. I love that. CO was CO2 value was 35, ultimately intubated CO2 with etomidate and succinylcholine because she had a gag reflex by now. And her CO2 was 38 and 35, so very good. On arrival, she has a 12 lead with sinus arrhythmia. I really don't enjoy the pictures of the 12 lead. I really like it if you can download it from your LifePack so that I can really see the 12 lead or any rhythm strips, because these are difficult at best to interpret, as you can see. So she has, with ROSC, she has a reasonable underlying rhythm. Now, she had many, many problems. As of day 2, she was she was still kicking on. She had it basically. She had gone into a torsades from severe hypokalemia and hypomagnesemia from her underlying issues. She did not require cooling because she was awake in the ER. She didn't need the cath lab because she had a reason for her torsades. She will ultimately go to the cath lab. Now, she's awake and alert and no complaints on day 2. So this is a 100%, we're going to call that a cardiac arrest save. But this goes to, and a lot of people do not have a structural, they go into the, say, why don't we take all these to the cath lab? Well, if there's a reason for their cardiac arrest and they don't need to go to the cath lab, there are kind of rules governing us as to who goes to the cath lab. They want some science there. Now, this is an interesting, very fascinating case. Called to the tennis center. Bystanders led us to the bathroom with the patient lying on the floor with an AED placed from the tennis center with CPR in progress. Patient has been shocked by the AED one time. 47-year-old man who'd been playing tennis, said he wasn't feeling well, went to the bathroom, short of breath, then he collapsed, and they started doing stuff on him. There's his first underlying rhythm, which I guess we'll have to say at least the first one looks rather suspicious. Well, it's kind of wavery under there, but I guess we'd have to call it VFib. So he was shocked by the machine, by the AED once. Rhythm is VFib. He's shocked twice more with CPR and epi given. His rhythm is now PEA. CPR, epinephrine, Narcan is given just because the tennis players are often, overdosing. My experience, anyway. There's a very good book out there you should read called The Tennis Partner. It's about a physician who's a narcotic drug abuser. Rhythm, VFib, shocked again, possible torsades, shock number 4, that's number 4 by ALS. Magnesium is given, and then he gets ROSC. Sinus rhythm, blood pressure 137, 12 lead ST elevation of V1, V2, and V3. tolerated the OPA, which is not necessary, then he begins gagging on it. OPA is removed, purposeful, has some purposeful movement, transported to the staff. Here's his 12 lead, his leads again, and unfortunately, once again, it's a picture. This is a 12 lead, shows, I guess we have to interpret some ST segment elevation in the lateral leads, or the anterior leads and lateral. Okay, now, in the hospital, he had an anterior STEMI. He was intubated in the ED because he remained essentially unconscious. He did respond to pain and movement, but he stayed unconscious. He went to the cath lab. He had a percutaneous intervention of his LAD. During the procedure, despite the fact that they ballooned him, put in a stent, he had extreme hypotension. He essentially had a 10% ejection fraction. That's not good. Almost everybody in this room has about a 60 to 90% ejection fraction. Anything under 30 is considered severe cardiac dysfunction. They put an Impella device, which is a device that they put in. It's a left ventricular assist device, but it's put into in the cath lab. It's put into the aorta, so helps to give some forward pump. He went to therapeutic temperature management, which is hypothermia protocol, because he was still not awake. He was in the CICU on a vent, on the Impella, on multiple, and I've done more checking on this since that time. He was on multiple meds to maintain his blood pressure. It wasn't working. So he's been transferred to Emmanuel and put on ECMO, extracorporeal membrane oxygenation. In other words, a heart-lung machine thing to keep him alive and hopefully take all the workload off his heart, and hopefully that will return to normal. He's got normal TIMI 1, TIMI 3 flow through his coronaries, but he had severe shock damage to that ventricle, which is not maintaining his blood pressure. So we'll have to, he was doing okay when I last checked, which is earlier, or last week, but transferred. He's, on ECMO, he can wake up and, but he'll still be, the machine will be running everything, maintaining his oxygenation and blood flow.
Did the hospital have any known history for him?
No. We had trouble finding his name even because no one really knew who he was at the thing, and his wife wasn't there, and they had no way of chasing it down originally. Okay, code 3 for possible cardiac arrest, 90 kilogram male syncope, patient doesn't speak English, family speaks poor English, patient suddenly became unresponsive, fire states patient was sitting in a chair on their arrival, weak and pale, moved patient to the floor, partial med list available but unknown, further information, unknown if he's ever had symptoms like this before, patient supine, on the floor, airway patent, breathing adequate, weak and slow radial pulse, pale, diaphoretic, nonverbal, no response to pain, improved color and blood pressure with him supine. Well, patient vomited several times during transport, able to clear and maintain airway after. Pulse decreased slightly after diltiazem. That was my first hint. What is this rate and rhythm? The rate is slow, right? What's his rhythm? What's his rhythm? Well, you have to use Dr. Whitworth's favorite diagnostic tool here. Do you see any P waves here? Do you have to lie about? Do you have to give me fake news to tell me there's a P wave there? Because I can only find fake news P waves here. And if you stand back and look at the top thing, which is just a rhythm strip, it's lead 2, it is irregular. This is atrial fibrillation. Is there anything in my orders that tell you to treat atrial fibrillation? I already gave it away earlier. I said no. The only thing you treat atrial fibrillation for is rapid ventricular response. If it's symptomatic. Is there rapid ventricular response? No. Matter of fact, what should this guy have been treated with? Fluids for one, because he didn't have any rales and rhonchi. And what's the other thing? Well, diesel works too. He unfortunately got some diltiazem. He also got some ondansetron because he complained of nausea and vomit, and he was vomiting on them. And then they got some diltiazem and put on a drip, and then they stopped it and he slowed. And what can we expect happen to this guy who actually has a blood pressure 132/102 to start with? But by the time he got to the ED, we don't have any significant blood pressure, which is kind of to be expected, actually. And his second, his second 12 lead sort of also means it's a little slower, which is so what did he need for a bradycardia if you thought it was symptomatic? Oh, I'd start with atropine. And incidentally, both the fire medic and the AMR medic, who have been, this is not a case unknown to them. They've already been discussed. They both realized, like, gosh, I could have had a V8, when they got to the ED. They said, now why did we give that? Because that's really not the treatment for bradycardia, and it's not the treatment for, no. Happily, this guy didn't have anything bad happen, and he responded to actually a little atropine. He got, I think, 0.5 of atropine at the ED, and he perked right up. Now, otherwise, your treatment for extreme bradycardia, if he was symptomatic, would be atropine. Then you think, well, do I want to pace this guy, or do I want to try maybe a little epi drip or something to make his heart beat a little better? But his blood pressure was really good, for an old guy. And I think that he'd probably do just fine with a little atropine. If he hadn't had the verapamil, he probably would have gotten better just with the ondansetron, because probably his nausea is what's making his vagal stimulation slow his heart rate. So the take home from this is we don't treat atrial fibrillation per se. There's nothing in your orders that says treat atrial fibrillation. It says treat atrial fibrillation with rapid ventricular complex if the patient is symptomatic. And don't ever treat bradycardia with diltiazem. It's not, treat it with bradycardia medicine. Okay. Yeah, well, as one of my old partners used to say when I asked him why he hired this particular doctor who was really not a good doctor, he said, well, if you can't hire good ones, hire lucky ones. We're lucky sometimes. Okay, but nobody gets lucky out there. We want to do the right thing. Okay? All right, what's next month? Skills? Or is it a lecture? Okay. Next month will be a lecture month too. Skills happen in
It's the
May, I guess.
CIGU.
Yeah, we'll find something. So keep in mind, remember that you have to have X number of live presentations. What?
He was fine.